Hello, this is Dr. Eric Lindquist. We're back with Sono-Minutes, and we're going to address a very common scenario that we see from a clinical sonography standpoint. You have a mass in the abdomen, whether you see it on radiographs, you palpate it clinically, and then you put a probe on it, and then you want to know, is this a splenic mass, or is this a liver mass, or is it coming off of something else, adrenal, pancreas, anything else in that region? So as we can see here, typical Labrador, or actually this is a Lab Great Dane cross with this hypoechoic undifferentiated mass and enhanced mesentery. I'm going to slow this down just a touch. We can walk right through it here, and we see this parenchyma is giving rise to this mass. But here's the liver and gallbladder. So we know this is liver and gallbladder, and then the mass right here. Well, is the mass belonging to the liver? Kind of looks like it, right? Or is it belonging to the spleen? And this makes a big deal surgically. So what I like to do is I go back and I recognize the normal parenchyma of an adjacent organ that it could be belonging to. In this case, if we look at the spleen and we see the splenic hilus here, we know all of this parenchyma is spleen. So I'm going to walk through my splenic clips, and this is why we always make definitive diagnosis on video clips, because we can move back and forth. So this is a splenic hilus. So I know this is spleen. It's a little bit heterogeneous. There's these little micronodular, capsular, expansive pathologies going on, which is concerning. But then we follow the capsule. I want you to watch the capsule, curvilinear theory here. And as we watch the capsule goes around the mass. Therefore, if I back up, I know this is the mass. What does this parenchyma belong to? If I back up and follow the capsule going around the mass, you see all this fuzzy fat because of adhesions, and upon the expansive pathology, the body's trying to wall off the pathology. And we get back, we're following the capsule back, and we get the splenic hilus. So we know that this mass belongs to the spleen. Even though it looks in this view like it belongs to the liver is buttressing up against the spleen. And but you can see that the splenic capsule clearly separates from the liver here. So it's all about following this capsule to see where the capsule goes around the mass, and therefore the mass belongs to the spleen. Obviously, we want to screen the liver for concurrent metastasis and not just nodular changes. Remember, dogs, 70% of dogs over 7 will have benign nodules in their liver. So don't call a metastatic lesion unless it is definitively cavitated or disruptive, and not just little hyperechoic nodules like this sort of thing that's not disrupting anything. You see the curvilinear patterns working through this little blotch. It's like a lipogranuloma or something similar, right? No, those are not typically metastatic lesions. Obviously, you want to always inspect the liver and get biopsies when you go in on this type of surgery. And if the splenic mass is isolated, then it very well could be histopathologically benign, but obviously this is bleeding and it needs to have surgery right away. But we know that mass belongs to the spleen. Here's a right adrenal, the left adrenal was fine. So we know this wasn't an adrenal mass. The pancreas was not a player. But we also get another view of this mass from the caudal approach. Before we saw it was a cranial to caudal approach to the mass, and now we're going caudal to cranial to the mass. The sonographer's moving in, and we know that this is the spleen because here's your splenic vasculature going right through the middle. So we have the capsule, we have some colonic artifact next to it. You can see there's no separation from the mass to the parenchyma. There's no capsule separating this mass from the parenchyma of the spleen. So we know it's deriving from the spleen itself. And you can see the splenic vessel, the splenic vein going right into the mass itself. So you know that is continuous with the splenic parenchyma as opposed to contiguous, right? And so we know that is a splenic mass because it belongs to the spleen. The capsule goes around it, and the splenic architecture dives right into it without getting separated by another organ capsule or the splenic capsule itself. So it's all about following the lines. You see the capsule goes up around the mass itself and then gets nebulous because of the adhesions going on. But there's no organ capsule separating the mass from the internal parenchyma of the organ of reference. So hopefully this curvilinear blip will help you distinguish splenic masses from hepatic or adrenal or other or pancreatic masses or even intestinal masses that can push up in the spleen. And remember, if you don't see a normal spleen, always go left upper intercostal, because if there is a hepatic mass or even a pancreatic mass or an adrenal mass here that's occupying the splenic fossa, the spleen goes north towards the spine of the patient, and therefore you have to image up in the upper left intercostal region to be able to see a spleen. It'll be typically pushed up against the dorsal part of the body and of the abdominal cavity, and often very small if it's volume contracted. So anyway, hope this little tip helps you distinguish splenic masses from other, so you can go in and find surgically what you saw sonographically. Anyway, hope you enjoy our Sono-Minutes. Give us plenty of feedback. Join us at sonopath.com.